Hello, everyone. Welcome to Strabismus Case Files webinar. Thank you so much for CyberSight for giving me this opportunity. And I'm really surprised about the number of participants who registered to the webinar. I think we have reached around 3,800 eye care health professionals who registered from over 160 countries. So thank you for everyone who registered, and thank you for everyone who attended this session. I hope that the session will be helpful. And during this session, I'm going to present a variety of strabismus cases, ranging from simple comitant strabismus cases to more advanced paralytic, restrictive, and resurgery cases. We will discuss the management plan and the long-term follow-up for some of the patients and lessons learned from each case with surgical videos of selected cases. So poll question number 1, where are you in training? Are you a junior resident, senior resident, general ophthalmologist, pediatric ophthalmologist, or allied health professional, whether optometrist or ophthalmic nurse? That will help me a lot in tailoring the content during the webinar. So 44% are allied health professional, with 22% general ophthalmologist and junior resident. Okay, great. So let's start. A tale of a child with an inward eye turning. So I will start with discussing cases of esotropia. So let's start with infantile esotropia. As you all know, infantile esotropia, usually the patient will present in the first 6 months, and patients usually have moderate to large constant ESO deviation more than 30 prism diopter. And usually these patients have no significant refractive error, and usually they have normal for age refractive error, so it's not related to hypermetropia. So first case, this is 1.5-year-old female presented with inward deviation since birth. On examination, she had central steady maintained fixation in the right eye and central steady unmaintained fixation in the left eye. And you can see here that the patient had left esotropia. Alternate prism cover test at near esotropia equals 40 prism diopter. Full extraocular motility, anterior posterior segment normal. Cycloplegic refraction repeated on 2 visits, and on both visits it was only +1 diopter sphere, which is not significant for a 1.5-year-old child. So impression, infantile esotropia with unmaintained fixation in the left eye. So I started right away, right eye patching 1 hour daily till the patient maintained fixation in both eyes. And once the patient will maintain fixation in both eyes or holding fixation on both eyes, that means that the child has a good vision in both eyes, most probably. So what about the management? I did bilateral medial rectus recession, 10.5 millimeter from the limbus and 5 millimeter from insertion. And post-operatively, 2 weeks, the patient presented with residual esotropia around 16 prism diopter, and that is totally normal in patients with infantile esotropia. Usually on the immediate post-op, within the first 1 or 2 months post-operatively, patient will have residual esotropia that will improve with time and full extraocular motility. Now child is almost 3-year-old. After 15 months follow-up, what happened to the patient? So after 15 months, patient is orthotropic at near and at distance, full extraocular motility, and everything is totally fine. And I advise the patient to follow up every 6 months. That is the one of the most important messages. Even if the patient become ortho, you need to follow up the patient for the vision, for any other visual problems. So regular follow-up is a must. So this is the nomogram that I usually use for infantile esotropia, and you will get to see that the numbers, the measurement are from the limbus, not from the media rectus insertion, and that is because in many cases of infantile esotropia, usually the media rectus insertion is not typical 5.5 millimeter. They might have 5 millimeter media rectus insertion or 6 millimeter in some cases. So it is more accurate to measure the recession from the limbus. And I took this table from pediatric ophthalmology book Taylor's. So all eye care health professionals who examining small kids will have a lot of difficulties. So you need to establish a good initial rapport, maintaining a calm, pleasant demeanor, interact, play with, or entertain the child while obtaining needed information. And before taking the child to operation theater, you need to have at least 2 visits with consistent measurements of the deviation to cycloplegic refraction to make sure that this is not a case of hypermetropia or accommodative esotropia, and the patient will have alternate fixation. That means equal vision, most probably in both eyes. Then you can do the surgery for patients with infantile esotropia. Amblyopia treatment, you need to check the fixation preference in very small kids. If I for 1-year-old children, if cycloplegic refraction revealed hypermetropia of +2 diopters or more, give full cycloplegic refraction that might improve the deviation. So lessons learned, aim for small esophoria less than 8 prism diopter. Many infantile esotropia will have residual ET 10 to 15 prism diopter in the immediate post-op visit that will improve gradually with time, like this patient, and regular follow-up visits to check alignment, fixation preference, and need for glasses if the patient had residual ET, and use the above mentioned nomogram. Second case, that is a 1-year-old child with inward deviation since the age of 1 month. On examination, central, steady, maintained fixation in both eyes, positive cross fixation, and having cross fixation in both eyes means that the child using both eyes equally, and most probably the child does not have amblyopia. Alternate prism cover test at Near reveals esotropia of 80 prism diopter. That is a huge esotropia, very large angle esotropia with full extraocular motility. Everything else is normal. Cycloplegic refraction only +1.5 diopter in both eyes. So impression, large, infantile esotropia. So what's your preferred approach for such a case? Would you do bilateral medial rectus recession only, or bilateral medial rectus recession with unilateral lateral rectus resection, or augmented bilateral medial rectus recession doing recession plus Botox injection in the medial rectus muscles to augment the effect of the recession? So what would you do in such case? Of course, all these options are valid, and I will discuss with you shortly what I have done. Okay, so 60% said bilateral medial rectus recession with unilateral LR resection, and that is what I have done. So bilateral medial rectus recession of 6 millimeters with right eye lateral rectus resection of 6 millimeters. Post-operative 1 week, patient came with esotropia of 14 prism diopter, and last follow-up after 6 months, patient had only small esophoria around 8 prism diopter at near and 3 prism diopter at distance, which is a great result with full extraocular motility. So lessons learned from this case, In patient with large infantile esotropia, which is more than 60 prism diopter, if you are sure about your measurements, whether Kremsky or the golden standard alternate prism cover test, you can do 3-muscle surgery according to the nomogram that I have shown. If you are not sure whether you are getting variable measurements in different visits, or the child is very uncooperative and you cannot get proper measurements, I would suggest doing staged surgery. Start by doing bilateral medial rectus recession, 6 millimeters, and counsel the patient that the child will definitely need another surgery for the residual esotropia after 3 to 6 months. So you can do whether unilateral or bilateral LR resection for the remaining esotropia. That is much better than doing 3-muscle surgery and if you are not sure and getting consecutive exotropia. Let's move to the second chapter, acute acquired comitant esotropia. So this boy is a 5-year-old presented with sudden inward deviation for 6 months. No diplopia, no other neurological symptoms or signs. History of excessive use of near devices, around 2 to 3 hours daily. On examination, uncorrected visual acuity, 6.6 in both eyes. No significant refractive error. Alternate prism cover test, esotropia 45 prism diopter at near and 45 prism diopter at distance with full extraocular motility. Because of that, I diagnosed the patient as acute acquired comitant esotropia. So to know the difference between acute acquired comitant esotropia and paralytic or 6-nerve paresis or palsy, patient with 6-nerve palsy or paresis will present with limitation of abduction. Usually the angle of deviation at distance will be more than the angle of deviation at near. Anterior, posterior segment, everything is normal. So the parents were very stressed about their child. So I ordered MRI brain without contrast just to make sure there is no neurological problem underlying, and it came to be normal. I started the patient on alternate patching 2 hours daily to prevent or to decrease the amount of suppression that can be happen because of the esotropia. And follow-up visit after 1 month, 3 months, and I got a consistent measurements in each visit, esotropia of 45 prism diopter. So I have done bilateral medial rectus recession of 6.5 millimeters. Post-op 1 month, patient is orthotropic with full extraocular motility. And here you can figure out that the amount of medial rectus recession for 45 prism diopter is little bit more than the numbers that we are using for infantile esotropia. And that's true. In cases of acute acquired comitant esotropia, you need to add around 0.5 millimeter add to the normal amount of recession for other cases. Post-op 1 month, patient is orthotropic. Everything is fine. Now the child is an 8-year-old big boy. So 3 years post-op follow-up. Patient still orthotropic, only small esophoria, 5 prism diopter at near, 3 prism diopter at distance with full extraocular motility, and also the stereopsis shown 160 seconds of arc. So let's move to the third chapter in esotropia. High AC by A ratio, those troublesome cases that usually every strabismologist and every ophthalmologist will feel stressed about these cases because the surgical results usually are not so good. So let's discuss the case. This is a young male, 2.5-year-old, presented with inward deviation 1 year ago on examination, fixation, unmaintained fixation in the right eye, maintained fixation in the left eye. Alternate prism cover test shown at near esotropia of 80 prism diopter. and at distance only 50 prism diopter. So that huge difference between near and distance measurement, 30 prism diopter. So that patient had high accommodative convergence per accommodation. And he had something called convergence excess esotropia or high EC by A ratio esotropia. Patient also had inferior oblique overaction in both eyes, +3 in the right eye, +2 in the left eye, with superior oblique underaction, -2 in both eyes. Anterior segment normal, posterior segment shown fundus extorsion in both eyes, and that is explained by the inferior oblique overaction. Cycloplegic refraction revealed +4 and +3.5 diopter. So I give the patient the full cycloplegic refraction. I started the patient on patching the left eye, so the vision in the right eye will improve. Amblyopia treatment continued with a 3-month follow-up. Every 3 months, I would see the child, repeat cycloplegic refraction. After 1 year of regular visits, parents wanted to do the surgery. Before that, parents were skeptical and they were stressed about doing the surgery. So my message here, do not push the parents for the surgery. Explain everything, the pros and cons of the surgery, the advantages, the disadvantages, the outcomes, success rates, everything, and then let them decide. So after 1 year, the parents finally wanted to do the surgery, and now patient is holding fixation in both eyes, central steady maintained fixation in both eyes. So what's your preferred approach? Whether you will do bilateral medial rectus recession and you will use the 50 prism diopter, the target distance deviation, or bilateral medial rectus recession and you will take the target angle is the mean deviation, that means 80 plus 50 divided by 2, so you will aim for 65 prism diopter, or you will do bilateral medial rectus recession, the target angle, the distance deviation with posterior fixation suture or Faden operation. So these are the 3 options. Okay, so the 42% said bilateral medial rectus recession with the target mean deviation near plus distance divided by 2, and then 38% bilateral medial rectus recession with posterior fixation suture, and that is what I have done actually. So the surgical plan, bilateral medial rectus recession of 6 millimeters to correct the 50 prism diopter esotropia, and I added posterior fixation sutures 14 millimeter from medial rectus insertion to correct the convergence excess. And I did also bilateral inferior oblique recession for the inferior oblique overaction. What happened after 9 months? So vision is 6.9 in the right eye, 6.6 in the left eye with glasses. Alternate prism cover test at near, small esophoria, 8 prism diopter. At distance, only right, small hypertropia, 6 prism diopter at near and at distance, with residual inferior oblique overaction, +2 in the right eye and +1 in the left eye. So this is the surgery. So here I'm isolating the medial rectus muscle using 6-0 vicryl suture. And here I'm planning to do a 6 millimeter recession. So I measured 8 millimeter from the medial rectus insertion and I put 5-0 ethibond sutures, non-absorbable sutures on either side of the muscle. So here I'm just re-measure, making sure that my measurements are correct. So 2, 1, and After that, I will disinsert medial rectus muscle from the insertion and doing the medial rectus recession 6 millimeters from the medial rectus insertion as usual. So here I'm taking scleral bite 6 millimeters from the medial rectus insertion and tying the muscle, securing the muscle. After securing the muscle now, I will take the scleral bites 14 millimeter from the medial rectus insertion and tie the non-absorbable sutures. Here tying the Fadden sutures and finalizing the surgery. Okay, so now we will move to the second part of the webinar, a story of a man with eyes turning outward. So exotropia cases. So this gentleman, 22-year-old male, systemically free, presented with outward deviation more in the left eye for more than 3 years. On examination, vision is good, fixation is good with right eye fixation preference, exotropia of 50 prism diopter with right hypertropia of 9 prism diopter at near and at distance with full extraocular motility and no oblique overaction, no fundus torsion. So what I had done bilateral lateral rectus recession of 7 millimeters with left medial rectus resection of 6 millimeters to correct the exotropia of 50 prism diopter. And I have done half tendon upshift of both lateral and medial recti in the left eye to correct the 9 prism diopter of vertical deviation in the left eye. So this is the picture of the patient post-op. Patient now is orthotropic, and that surgery, that very simple surgery, changed the life of this patient. He had a very high self-esteem, high confidence after the surgery. And it's really fascinating how strabismus surgery can change lives of the patients. So lessons learned in a patient with exotropia, angle 50 prism diopter or more, I prefer to do 3 muscle surgery for better results and minimizing lateral incompetence. In patients with a small vertical deviation with no oblique overactions, you can do horizontal muscle vertical transposition to address vertical deviation. And remember, full tendon vertical transposition of the horizontal recti would correct up to 14 prism diopter. Moving to the second case, that's a child who is 2.5-year-old, presented with outward deviation since the age of 1 year. On examination, central steady maintained fixation in both eyes, exotropia 50 prism diopter, inferior oblique overaction +4. You can see here, severe inferior oblique overaction in both eyes, +4 inferior oblique overaction in both eyes, with bilateral fundus extorsion, cycloplegic refraction +1. So I did not give that +1. Actually, I gave the patient over minus glasses, and that is one of the ways that we can use in children with exotropia to try to push the surgery bit late as a temporizing measure. We can give them over minus glasses, whether in this patient I give -1 diopter sphere over minus glasses, and also I started the patient on alternate patching. Some patients might respond to this and might get better control with time, but unfortunately compliance was very poor from the family and from the child, and I measured the angle of deviation for 4 or 5 visits, and in all these visits the angle of deviation was stable. So in such case, what's your preferred approach? Whether you will do bilateral lateral rectus recession only, or you will do bilateral LR recession with tendon upshift for V pattern, or you will do BLR recession with inferior oblique weakening procedure. So what do you think? In such patient with exotropia 50 prism diopter and inferior oblique overaction of +4 in both eyes. Great. So 53% of the participants agreed with my decision, bilateral LR recession with inferior oblique weakening. So what I usually prefer in such cases, especially with significant inferior oblique overaction, is to do inferior oblique weakening procedure on the same session. If you are having V pattern exotropia with no inferior oblique overaction, at this point of time, you can do the tendon upshift of the lateral recti. So in this patient, I have done bilateral LR recession 10 millimeters with inferior oblique anterior transposition in both eyes. And I choose anterior transposition because of the large grade of the inferior oblique overaction. And post-operatively, patient is orthotropic and inferior oblique overaction improved significantly. What happened after 2 years? The child now is 5-year-old with 6/6 vision in both eyes and alternate prism cover test at near ortho and at distance small exophoria of 5 prism diopter with residual inferior oblique overaction +1 in the left eye. So lessons learned from this case: in small children less than 4 years, I prefer to start with conservative treatment as over minus glasses or alternate eye patching. In patients with constant exotropia whom above measures failed and I could get stable, accurate measurements, you can do the surgery, but always aim only for orthotropia. Never aim for overcorrection like all the children or adults, where we usually aim for small esotropia, 5 to 10 prism diopter, but in small children, it's better to aim for orthotropia. So this is the surgery: inferior oblique anterior transposition, inferotemporal fornix incision, 7 millimeter from the limbus. Then holding the tenon and do a vertical cut, reaching the inferior oblique muscle, hooking the inferior oblique muscle, making sure that you take the whole muscle using the artery forceps and cutting in between, and then isolating this part using 6-0 vicryl suture, the part that is attached to the origin of the inferior oblique muscle, hooking inferior rectus muscle, and putting the muscle exactly at the same level of the inferior rectus insertion, 2 millimeters away from the inferior rectus insertion, and securing the muscle. Very simple and very powerful procedure. Going to sensory exotropia. So this is a 45-year-old female presented with loss of vision in the left eye post-penetrating trauma at the age of 6 years, and she had already intraocular surgery at that time, and she started having outward deviation since the age of 9 years, and that deviation increased with time. So vision is only 6/120 in the left eye with corneal scar and intraocular lens, and she has extra large exotropia around 100 prism diopter using Kremsky test. And the problem with this patient that she lived with this exodeviation for around 35 years, and unfortunately whenever she will go to an ophthalmologist, he or she will tell her that the deviation will recur in 6 months. So she was skeptical. She wanted to get her deviation corrected, but she was afraid. So what I had done here, I did lateral rectus recession of 10 millimeter with left medial rectus resection of 9 millimeter, using the stump from the medial rectus and putting it in the lateral rectus muscle, then doing the LR resection of 10 millimeter. That technique called true muscle transplantation. It's very powerful technique that will correct up to 100 or 110 prism diopter of deviation, whether exodeviation or esodeviation, using only two muscles. So this is the true muscle transplantation technique in a brief. So after doing the medial rectus resection, you take the medial rectus muscle stump, attach it to the lateral rectus muscle using non-absorbable suture, and then doing your lateral rectus resection. So at 2 years follow-up, that was 3 days ago, what happened to the patient? Does the sensory exotropia recurs? Fortunately not. Patient still orthotropic with only -1 limitation of abduction in the left eye, and she is happy and she is satisfied with the results. Lessons learned. True muscle transplantation technique is helpful in patients with sensory exotropia more than 60 prism diopter, working only on two horizontal muscles. Doing LR resection with MR resection and true muscle transplantation can correct up to 100 prism diopter of exo. Sensory exotropia cases have higher success rate if you correct the whole deviation and kept the patient slightly esotropic initially, 5 to 10 prism diopter of esotropia, because those patients have the tendency for outward drifting after the surgery. So if you keep the patient with a very small esotropia, 5 to 10 prism diopter, usually you will get a long-term stable results. That is another case, 18-year-old female, 17-year-old female with even larger exotropia, around 120 prism diopter of exotropia. So I did the same measurements as the last patient. I did LR resection 10 millimeter with MR resection of 9 millimeters with true muscle transplantation. But unfortunately, after the operation, patient still had residual exotropia of around 40 prism diopter. So I convinced the patient to work on the sound eye, on the good eye, and the patient agreed on that. So I did LR resection of 8 millimeter with MR plication of 7 millimeters on the left eye, the good eye. And fortunately, the patient now had a very good alignment. So doing surgery on the sound eye is a viable option, and you can use it if you did already maximum recess resect on the amblyopic eye. Now moving to a story of eye that is not moving freely. We will speak about paralytic strabismus. Starting with a patient with complete 6-nerve palsy on both eyes. You can see here patient is having esotropia in both eyes, limitation of abduction, even the eye is not reaching the midline in both eyes. So this gentleman is 40-year-old. He had a history of head trauma 1 year ago, presented with inward deviation in both eyes. On examination, vision is good, no significant refractive error. Alternate prism cover test revealed a huge esotropia, 110 to 120 esotropia, with limitation of abduction in both eyes -6, and rest of cranial nerves intact, anterior, posterior segment normal. So the impression bilateral, complete 6-nerve palsy post-trauma. What's your preferred approach in such patient? Would you do bilateral medial rectus resection with bilateral lateral rectus resection, or bilateral medial rectus resection with Hamelsheim procedure, or bilateral medial rectus resection with superior rectus transposition? So let's remember that this patient had complete 6-nerve palsy, not incomplete. And in such patient, usually lateral rectus muscle is not working. So even if we did lateral rectus resection, we might not get the result that we want. Even with very large resections, you might not get proper results. So the results, 33%, first option, 34%, second option, and 33% third option. So I get equal results in the three options. Actually, what I have done, I did bilateral MR recession 6 millimeters using adjustable sutures technique, bow tie technique, with bilateral superior rectus transposition with posterior fixation suture. And this procedure simply, I am transposing the superior rectus from its original position, and I transpose it just superior to the lateral rectus muscle insertion in both eyes. And I did bilateral MR recession using adjustable suture technique because in such patient, you cannot really know the amount of correction that superior rectus transposition will give exactly. So adjustable sutures will give you the option to increase or decrease the recession amount according to the deviation after the patient wake up. Postoperatively 1 month, patient had exophoria of 3 prism diopter at near, esophoria of 5 prism diopter at distance, and the limitation of abduction improved from -6 to -1 and from -6 to -1.5. And the patient now had no diplopia at near or at distance. Lessons learned: incomplete 6-nerve palsy, limitation of abduction with -4 or more, LR resection will not work. Transposition surgery is mandatory to improve abduction and get satisfactory alignment. Better to do MR recession using adjustable suture technique to titrate your results in the immediate post-op. Coming to cases of incomplete third nerve palsy, that young man, 20-year-old, victim of road traffic accident, presented with left outward deviation for 1.5 years. On examination, vision is good with glasses. He had exotropia of 40 prism diopter, 45 prism diopter, at near 35 prism diopter, and that is very common in patient with third nerve palsy. You will get more exotropia at near than distance because the patient had medial rectus under action. And there is limitation of A deduction -1, limitation of depression, and limitation of elevation. Everything else is normal. So the patient had left traumatic, incomplete third nerve palsy with pupil involved. As you can see here, the patient had dilated pupil in the left eye. So what I had done, left medial rectus resection of 6.5 millimeter with lateral rectus recession of 9 millimeter using adjustable suture technique. And post-op 2 years, patient still is orthotropic with limitation of elevation and depression as pre-op, but on the primary position, patient is orthotropic. Palsy, routine nomograms doesn't work. Remember, in this patient with 45 and 35 exo, I have done 9 millimeter recession with 6.5 resection. That amount of recession and resection will correct up to 50 to 55 prism diopter of exotropia in patient with normal muscles. And it's always better to use adjustable sutures technique. This young lady, 30-year-old with outward deviation for 20 years post-head trauma. On examination, she had large exotropia, 60 prism diopter with hypotropia, 40 prism diopter. So that is kind of cases that is more complicated than the previous case. The previous case, the patient had only horizontal deviation, but this patient had mixed horizontal and vertical large deviations with limitation of elevation and limitation of A deduction and limitation of depression. in the left eye. So I did the surgery on two stages. So firstly, I worked on the right eye, the sound eye, the eye with no problem. I did LR recession of 9 millimeter with MR resection of 7 millimeter with full tendon downshift, with left LR recession of 9 millimeter with inferior rectus recession of 6 millimeters. After 5 months of the first surgery, I did second stage surgery to correct the residual hypotropia and exotropia. So I did right eye superior rectus recession of 5 millimeter and left eye medial rectus plication and superior rectus plication. So as you can see, we worked almost on 7 recti muscles on the two stages to get proper alignment. Post-op 10 months, patient now is exophoric, only 10 prism diopter at near, and small left hypotropia, 8 prism diopter and 6 prism diopter. And here you can see also that not only the strabismus improved, even the ptosis improved in the patient. So how the ptosis improved in this patient without ptosis surgery? That happened when we did contralateral recession resection. That will create a fixation duress and will make the ptosis improve because that patient had aberrant regeneration. So preoperative counseling regarding success rate, possibility of second surgery, presence of diplopia in different gazes other than the primary position. Remember, we cannot make this patient fuse in all the gazes. Mainly, we aim for binocular single vision in the primary position and the reading position. That if we reach this point, that is the best outcome. And your expectations must match patient's expectations. In cases of third nerve palsy, adjustable suture technique is crucial to get better results. Moving to the last cranial nerve palsy associated with the strabismus, the fourth nerve cranial nerve palsy. So this small child, 4-year-old with a history of epilepsy and developmental delay, presented with left upward deviation noticed by the mother since the age of 6 months. On examination, she had unmaintained fixation in the left eye with left hypertropia of 30 prism diopter, with inferior oblique overaction +4, superior oblique underaction -2. Cycloplegic fraction, she had a significant refractive error, so I started the patient on glasses and doing right eye patching 2 hours daily to treat the amblyopia in the left eye, follow up every 3 months. So in such case with left fourth nerve palsy of 30 prism diopter, what's your preferred approach? Would you do inferior oblique recession or myectomy only, or inferior oblique recession or myectomy with ipsilateral superior rectus recession, or inferior oblique recession or myectomy with contralateral inferior rectus recession? Remember, this is a patient with left hypertropia of 30 prism diopter. So what would you do in this patient? Okay, so 52% of the audience choose to do inferior oblique recession with ipsilateral superior rectus recession. So in these cases, usually what we do intraoperatively, we will check for the force duction test in the left eye. If the patient had tight superior rectus muscle, and that can happen with long-standing fourth nerve palsy, then you need to do superior rectus recession. But if the patient had normal superior rectus tone, so it's preferable to do inferior rectus recession on the other eye. Why is that? Because when you do inferior oblique weakening plus superior rectus weakening in the same eye, you might end up with limitation of elevation, and kind of monocular elevation deficit picture. Okay, so if I'm having tight superior rectus, I must do superior rectus recession. But if it is not tight, it's preferable to do inferior rectus recession like this patient. And fortunately, patient post-op is having good alignment. So lessons learned in fourth nerve palsy, if the hypertropia is 15 prism diopter or less, inferior oblique surgery is enough to correct the hyperdeviation. But if the patient is having larger hyperdeviation, more than 15 prism diopter, so you need to do two muscles, whether to do inferior oblique plus SR in the same eye or doing contralateral inferior rectus as I explained. And always in such cases, aim for small undercorrection. Never aim for overcorrection. Aim for small undercorrection, 1 to 5 prism diopter, and remember, late overcorrections occur. Coming to a story of an eye with a mysterious condition. And I know these conditions that I will show now, many of the ophthalmologists will feel puzzled when they have a patient with these conditions. Starting with monocular elevation deficit. Remember, monocular elevation deficit is a limitation of elevation of the affected eye that is similar in both adduction and abduction. And MAD is one of the causes of hypotropia and can be associated with ptosis or pseudotosis in some patients. So this small child, 3-year-old, presented with left right upper lid drooping with downward deviation since birth. So she had right hypotropia since birth, and you can see here there is limitation of elevation in the right eye. On examination, she had right ptosis with right hypotropia of 45 prism diopter, that is large hypotropia, and FDT done intraoperatively, and it was negative. So the surgical plan was to do NAP procedure, augmented NAP procedure. So in NAP procedure, what we are doing, we are transposing both lateral rectus and medial rectus to put them on the lateral side and the medial side of the superior rectus muscle. And augmented NAP, usually I put posterior fixation sutures between the medial rectus, 8 millimeter from the medial rectus muscle to near the superior rectus muscle, and the same with the lateral rectus muscle. But unfortunately, after doing the first surgery, the patient still had residual hypotropia with exotropia that I didn't notice initially. So what I had done in the second surgery, I did inferior rectus recession with MR resection, or MR plication and LR recession to correct the exotropia. So as you can see in such cases with monocular elevation deficit, and especially if it is associated with exotropia, it's not easy sometimes to get your satisfactory results in one surgery. You might need to do multiple surgeries, and you need to counsel the patient about this. Coming to Brown syndrome, and just to refresh you about the Brown syndrome, patient with Brown syndrome usually have a problem in the superior oblique muscle. It is either short tendon or thick tendon, so the eye is not going upward. So those patients will have limitation of elevation on adduction, limitation of elevation, and almost normal elevation on abduction. Okay? So this is a 5-year-old female presented with both esotropia and limitation of elevation in the left eye. So that is some of the cases you might find two pathologists in the same patient, like this patient. She had esotropia and Down syndrome in the left eye. So the patient had esotropia 40 prism diopter with hypotropia of 15 prism diopter in the left eye. So what I have done, bilateral MR recession 5.5 with left superior oblique split lengthening, where I did like the Z myotomy of the superior oblique muscle. So that is a lengthening procedure that will relieve the Brown syndrome. Post-operatively, 8 months, patient had only esophoria of 8 prism diopter at near, ortho at distance, and the elevation is totally normal in the left eye. Coming to this case, 5-year-old male with downward deviation of the right eye with limitation of elevation, with hypotropia in the primary position. He had 35 prism diopter of hypotropia. So I had done for this patient something called suture spacer or chicken suture technique, where you put a non-absorbable suture between the two ends of the muscle. So you will do lengthening procedure for the superior oblique muscle, and it ended up with good results, normal extraocular motility and orthotropia in the primary position. FDT is mandatory to confirm Brown syndrome. Superior oblique lengthening procedure are better controlled procedure. Intraoperatively, repeat FDT after doing the surgery and avoid SO tenectomy because of the risk of superior oblique palsy or overcorrection. Duane retraction syndrome, 6-year-old female with inward deviation, limitation of abduction of -4. She had esotropia, 40 prism diopter at near, 50 prism diopter at distance. So in such case, esotropia with limitation -4, limitation of abduction -4, what's your preferred approach in such patient? Would you do bilateral medial rectus recession or left medial rectus recession with LR resection, or left medial rectus recession with superior rectus transposition? So remember, this is a case of left Duane, esotropic Duane, with limitation of abduction, with esotropia of 40 and 50 prism diopter at near and at distance. So what would you do in this case? Great. So 55% voted for the third option, left medial rectus recession with superior rectus transposition, and that is exactly what I have done. So let's see the patient post-op. So I have done left medial rectus recession of 5.5 millimeter with superior rectus transposition to putting it superior to the lateral rectus muscle insertion. And you can figure out here the limitation of abduction improved from -4 to -1 or -1.5. So if there is no globe retraction, you can do superior rectus transposition safely. And regarding the medial rectus recession, in Duane cases, do not do more than 5 millimeter. Otherwise, you might end up with overcorrection or consecutive exotropia. That is a 30-year-old male with outward deviation, abnormal head position, narrowing of the palpebral fissure, with severe upshoot on adduction and limitation of adduction. So what type of Duane this one? This is exotropic Duane or Duane retraction syndrome type 2 with exotropia and limitation of adduction. So I had done lateral rectus recession of 9 millimeters with Y splitting. So that is Y splitting procedure. You divided the lateral rectus into two halves, and you do the recession and make them away from each other 20 millimeters apart. And that will help in relieving the upshoot along with the exotropia because of the recession that we had done. Coming to the last case, consecutive exotropia. So this is a 17-year-old female who had strabismus surgery at the age of 6 years. She had esotropia, and on examination, she had 6/6 vision in both eyes with conjunctival scarring over both medial recti and left lateral rectus in the right lateral rectus, sorry. And the alternate prism cover test was 50 prism diopter of exotropia at near and at distance with very small limitation of A deduction in both eyes, minus half or minus 1. So what I had done, medial rectus advancement, 4 millimeter in the right eye and 4 millimeter in the left eye with resection of the stretched scar. And that is a very important point. Whenever you had a stretched scar in a patient with consecutive exotropia, you need to resect this stretched scar and put your sutures in the proper muscle with lateral rectus recession of 7 millimeters. And that is the patient post-op. She had very small esophoria, which improved over time. What happened after 2.5 years post-surgery? Patient still having very good alignment at near and at distance. So lessons learned, consecutive exotropia cases, if there is limitation of A deduction, it's always better to do medial rectus advancement. If there is no limitation of A deduction, so you can do either medial rectus advancement or lateral rectus recession. And for each 1 millimeter of medial rectus advancement and or resection, every 1 millimeter will correct around 3 prism diopter. And as I already mentioned before, better to use adjustable suture technique. So that is the video of the case. You can figure out here adhesions in the subconjunctival space. It's not easy to work on a patient with previous strabismus surgery, and it's always better to do limbal approach. Do not do fornix approach. It's always better to do limbal approach. And you will usually have a lot of bleeding, a lot of adhesions. You might need to use cauterization. So here I am hooking the muscle, and always in resurgery cases, you need to do the measurements from the limbus, Okay, and here you can see this is a part of stretched scar. This part is not a proper muscle, so you need to resect this whole part. If you put your sutures here and do the advancement, the patient will end up again with a recurrence of exotropia. So you need to put your sutures in the proper muscle tissue. After doing the resection, I measured 5.5 millimeter from the limbus, the original insertion of the medial rectus muscle, and I attached the muscle to the sclera and closing the conjunctiva. And again, in the resurgery cases, usually closing the conjunctiva is not an easy thing. So thank you so much for your attention. And I would suggest these books for further reading. So now we will start checking the questions. So is it safe to operate on two rectus muscles and one oblique muscle in the same eye during a single surgical session? Definitely. Oblique muscles does not count. So if you do only two recti muscles on the same eye, you can do one or even two oblique muscles on the same eye without any problems. How do you check for fixation? That central, steady, maintained way. So usually you will start, for example, checking this eye. So I will do occlusion of this eye and I will check if the fixation is central or not. If the eye is steady, non-nystagmus or not, then you will uncover this eye and check if this eye is still central, is still maintaining the fixation or not. Then you will do the same thing on the other side. Cross fixation, usually when the patient will look on that side, he will use this eye. And when he look on that side, he will use this eye. That is the cross fixation. How does correcting the LR along with MR help with post-surgical outcome? So if you, for example, are having exotropia more than 20 prism diopter, you need to work at least on two muscles. So you can work on both muscles, lateral rectus recession, medial rectus resection on the same eye to get the proper alignment. Patient has a squint in the age of 45, uh, past 2 years before accident, um, but vision has blurred in distance. Management should have done or not. I'm sorry, I'm not sure that I got the question. Tell about strabismic amblyopia. It's a very long topic, but what I can say, when a patient had strabismus in a very young age, suppression happened in the eye with constant deviation, and that will lead to amblyopia in that eye. Okay. Without surgery can't be fixed in such young age. In some patients, especially intermittent exotropes, with orthoptic exercises, with over minus glasses, with alternate patching, patient might not need surgery, and you might defer the surgery for some time. Why not trying bifocal lens in AC by A ratio case? Because the patient had esotropia at distance, 50 prism diopter, even with the glasses. He still had 50 prism diopter of esotropia. So we use bifocal lenses only if the patient is orthotropic with the glasses at distance or within 8 prism diopter of ESO. Then we use bifocal lenses to correct the near deviation. But if the patient still having residual esotropia of more than 8 prism diopter at distance and at near, bifocal lenses will not help. Why not splitting? Why splitting for the ESO case and high AC by A ratio? I heard about this technique for high AC by A ratio and for congenital esotropes with large angle, but I never done it in congenital esotropia cases. Is it a must for the patient to have good visual acuity before squint surgery? It is advisable to treat amblyopia before the surgery. Whenever you have a better vision, you will have a better surgical outcome, and the patient will have more stable results on the long-term follow-ups. So if you did surgery with patient with amblyopic eye, especially small children where you can still treat amblyopia, it's always better to maximize amblyopia treatment before going to the surgery. Why have tendon up and down in exo? That is because of the vertical deviation. That patient had a right hypertrophy of 9 prism diopter with no oblique overaction. So I decided to do a half tendon upshift. Can squint be treated with eye exercises? As I mentioned, in some cases with intermittent exotropia, orthoptic exercises over minus glasses can help. How to approach a patient with IXT with bilateral inferior oblique overaction with V pattern? Um, uh, if the control is poor and you can go for the surgery, whether you do BLR recession with inferior oblique recession, like the case I shown, with smaller numbers of LR recession since the patient had only 35 prism diopter in primary position. What are the early and late complications of true muscle transplantation? As what I have read from the literature and from my cases, I did not encounter any complications that is different from other strabismus surgeries. It's a very safe procedure with no problem so far with me in my hands, and also what I have seen in the literature, no complications different from other strabismus surgery complication. In superior rectus transposition surgery, how does the abduction in cranial nerve 6 pulse improve if the vertical muscle only contract in elevation, not abduction, because you will change the vector of the muscle. So when you are transposing the superior rectus to the lateral rectus insertion, you will put it just superior to the LR insertion. You make the superior rectus to elevate the eye and abduct the eye. So the patient will get some abduction because of the superior rectus transposition. So that is the point of doing transposition. And it's really a very powerful procedure that I have done in many patients with either sixth nerve palsy or Duane, and it's giving a great results. Are all strabismus cases manageable? I think all strabismus cases are manageable, but the success rate change from one case to another. For example, cases with congenital fibrosis of extraocular muscles, cases with complete third nerve palsy. Usually these cases are very tough and the success rate is not very good. So all cases are manageable, but you need to counsel the patient about the success rates, the need for resurgery. Maybe the patient might need second or third surgery to get satisfactory alignment. When do you adjust the adjustable suture? I usually do the adjustment after 1 or 2 hours after the surgery. So I keep the patient with adjustable sutures in the beginning of my list, and I do the adjustment at the end of the day, 2 hours, 3 hours after the surgery when the patient is awake. And I take the patient back to the operation theater and do the suture adjustment using topical anesthesia in most of the cases, because it's usually taking only around 4 to 5 minutes. For an infant under age 2 with infantile esotropia, would you not consider botulinum toxin instead of BMR recession? I don't have a large experience in Botox injections, but I usually prefer to do bilateral MR recession if I am getting consistent, stable deviation through 2 or 3 visits. Then I would prefer to do bilateral MR recession. All the studies that I have read about Botox stated that the child most probably will need more than one injection, maybe 2 or 3 injections. So that also the child will go for general anesthesia multiple times and the risk of general anesthesia. So I prefer to do bilateral MR recession if I am getting stable, consistent measurements. For management of bilateral sixth nerve palsy, could you consider augmented Nishida? Yes, I'm doing modified Nishida procedure now also for patient with sixth nerve palsy and patient with monocular elevation deficit. Maybe in the future, in another webinar, I will present some cases of the modified Nishida. It's a very powerful procedure, very nice procedure. Do you routinely use steroids ointment post-op? Yes, I'm using steroid antibiotic ointment post-operatively for all strabismus surgery cases. So the recommended books, Atlas of Strabismus Surgery for Dr. Kenneth Wright, by Dr. Kenneth Wright, Strabismus Surgery that was published by the American Academy of Ophthalmology by Dr. Edward Buckley, and Clinical Strabismus Management by Dr. Rosenbaum, Arthur Rosenbaum, and Kushner, Dr. Kushner book, Strabismus. Those 4 books are really very good, and I recommend these books for everyone. Guidance on alternate patching required. I use alternate patching if the patient is having alternate fixation, and it might help in some patients getting better control of intermittent exotropia. Is there diplopia after surgery? Sometimes, especially in patients with acute esotropia or acute strabismus, like the cases of third nerve or sixth nerve acquired pulses. Usually, if you did not correct the deviation exactly, the patient will end up with diplopia. Because of that, I usually use adjustable sutures in those cases. Amount of over minus to correct intermittent exotropia. I usually don't over minus so much. I give only -1 to -1.5, not more than that. What is the management of limited elevation after inferior oblique surgery? So sometimes if the patient had inferior oblique surgery and post-operatively he had limitation of elevation, the patient might have something called anti-elevation syndrome or fat adherence syndrome. And in such patient, if the limitation is severe and the patient is not satisfied, you can do exploration and check if there is any fat adhesion or if there is any fibrosis, remove these and the patient will improve. But usually these cases are complex cases. Can Duane retraction syndrome start to manifest in 70 years old patient if the patient complain of diplopia? I don't think so. Duane retraction syndrome usually will present early. It's a congenital disorder, and usually patient will present much earlier than this age. I would think of another diagnosis. Okay, in cases of esotrophic duane retraction syndrome after performing bilateral MR recession and SRT with residual esotropia, what to do next? You can work on the other eye. Yeah, definitely. You can do either lateral rectus resection or you can increase the amount of mid rectus recession to correct the residual esotropia in the other eye. Is it possible to treat exotropia with more than 100 prism diopter in one surgery? Yes, exactly. Definitely, that can be done, but it's not very easy, but it can be done, especially if you can work on the other eye on the same session, doing one more muscle in the other eye. How to properly measure and confirm PD pre-op? Can it be measured under anesthesia? No, it can't be measured under anesthesia. The patient must be not under anesthesia, alert to get measurements. So thank you so much. I think I have answered most of the questions. Thank you for your attention and thank you so much.